So in this lecture series, we are going to talk about pelvic inflammatory disease. Now, pelvic inflammatory disease, it's a it's an entity where you need to know about different criterias and different aspect. Okay, so pelvic inflammatory disease. So what are the pelvic organs? First of all, we should understand that we are talking about the uterus. We are talking about the fallopian tube. We are talking about the fallopian tube. We are talking about the ovaries. Okay. So we are not talking about the cervix. So if there is cervicitis, will this be considered under pelvic inflammatory disease? Never. Okay, it will not be considered under pelvic inflammatory disease. Okay. So first of all, I'll give you an outline and then we'll go into the pelvic inflammatory disease component. Okay. So if it is involving the uterus, so it is known as endometritis. If it involves the tubes, that is known as salpingitis, and if it involves the ovaries, is known as oophorytis. Okay. Now, what are the risk factors? So first of all, you should know about the risk factors of pelvic inflammatory disease. Okay, so risk factors for pelvic inflammatory disease is for PID. The most important risk factor for PID is if she's a menstruating teenager. Okay, so if she's a menstruating teenager. Okay, so menstruating teenager, multiple sexual partners, pregnancy, menopause, and IUCD. Okay, IUCD. So basically, risk factors can vary from start to end. That means she has started menstruating, she had ended menstruating. In between, she has multiple sexual partners. Okay, and for contraceptive purposes, she has used IUCD. So all these becomes the risk factors for pelvic inflammatory disease. Okay, so what is PID? Risk factors, presentation, management, treatment plan. Okay, so pelvic inflammatory disease is the acute or chronic clinical syndrome. It's the inflammation of the upper genital tract. It involves the uterus, the fallopian tubes, and the ovaries. Okay, now it can involve the pelvic peritoneum and the surrounding tissue structures. Okay, so it's usually bilateral. Now, the most important thing is what are the actual protective measures against PID. If you use a condom, that is a barrier method of contraception, or if you are practicing a healthy habit. Okay, healthy habit means healthy sexual intercourse. That means you have a single partner. It is not that you are having multiple sexual partners, and you're taking care of the vaginal pH. So normally vaginal pH is acidic because of the presence of lactobacillus. Okay, lactobacillus. Now if you make this acidic pH alkaline, then there is high risk that the organisms which were present there, the acidic barrier will actually prevent the organism to sit above. Okay, if it is alkaline. So alkaline happens in the case of Trichomonas vaginalis or bacteria vaginosis. So in that case, what happens is the bacteria, it can seed up, right? And if it seeds up, okay, it can lead to endometritis, fallopian tube salpingitis, and oophorytis, and it can also involve the pelvic peritoneum. Okay, and remember, the progesterone only pills are highly protective against PID. How? Because we know that progesterone only pills leads to increased cervical mucus. Okay, increased cervical mucus, and when there is an increased cervical mucus, what happens is the bacteria, it can't go up. Okay, and it also provides protection against PID. Okay, progesterone only pills is a very good drug. Okay, the ciliary movement of the endometrial lining. So suppose there is some foreign body or something over here. For example, the product of conception, it has not now fertilized. What will happen? Because the continuous beating mechanism and the uterine contraction because of prostaglandins, what happens is this will come out, right? The same ciliary movement action of the endometrium, it protects someone from PID. Okay, now I would like to let's talk about the criteria of PID. Okay, before even starting PID, I would like to talk about the criteria of PID. Very, very important. So there are three criteria, okay, of PID. So one is the minimum criteria, other one is the additional criteria, and the last one is definitive criteria. So the ways to remember this is very, very important. It's so important, I can't explain. Very important. Okay, so definitive criteria. So what is actually the definitive criteria? So remember, definitive diagnosis is made either by histopathology or radiology. Okay, so the same thing here also, or a surgeon looks into, so we have three important people over here in definitive diagnosis. We need a pathologist, we need a radiologist, and we need a surgeon. Okay, so in this way, if you remember, you'll understand everything. Okay, so pathologist for HPE, histopathological examination, is done by the pathologist and he will confirm the diagnosis. Okay, he will give you the evidence of endometritis, okay, or a radiologist will give you an information of tubo-ovarian abscess, okay, tubo-ovarian abscess by a transvaginal sonogram or an MRI, okay, by a transvaginal sonogram or an MRI. The person over there in the radiology department will give you the diagnosis that this is a case of transvaginal sonogram, or this is a case of tubo-ovarian abscess, okay, or it's a case of PID, infection from transvaginal sonogram or MRI. Okay, and the laparoscopic person, the surgeon, the gynecologist itself, looks into by the laparoscopic port into the uterine tract, and then she finds out that there is signs of PID. Okay, so laparoscopic evidence of PID. So these three gives you the definitive criteria for what is PID. Now, whenever we talk about the minimum criteria, so minimum criteria means the patient says, okay, the patient says, and then the patient comes to the department. So see here, it's very easy. In minimum criteria, there is one patient, she just goes to the department, goes to the gynae department and says that, ma'am, I am having lower abdominal tenderness, lower abdominal pain. So I just have this feature. Now see, I'm not evaluating anything. She just says that I'm having lower abdominal pain. I go for an examination. I see adnexal tenderness and cervical motion tenderness. So I see adnexal tenderness, okay, and cervical motion tenderness. Okay, I see both of these. Okay, so that becomes a minimum criteria. So what's an additional criteria? So what is an additional criteria? So additional criteria is basically, just remember that the woman will come, she is having lower abdominal pain, of course she'll have fever. So you find it out, you put a thermometer, because suppose she's a female from the village community. Will she see fever? No, she'll say I'm having some hot sensation, and I'm having some sort of hot sensation, and I'm having some sort of hot sensation, man, and I don't know what has happened to me. I just have the lower abdominal pain. Now she says that she's having some discharge. Okay, some discharge. So that is a mucopurulent discharge. Mucopurulent discharge is some vaginal discharge, right? She's having raised ESR and CRP. Now this you will find it out. Okay, and there is lab documentation of infection with gonorrhea or chlamydia, and you find this by liquid based cytology. Can you remember this? Whenever we talk about cervical interepithelial neoplasia, we talked about that. In cervical interepithelial neoplasia, if you go for a pap smear, it's not just pap smear that we are doing. We are going and finding out some sort of diseases, right? So what are the other diseases that are found, that are figured out, that are understood by pap smear? This is also often asked in the examination. Okay, so pap smear, or which is also known as papinoculose smear, it just does not find the cells in the transformation zone. It also finds out the infective foci. Now how are you going to remember what bacteria causes? So you can remember by the mnemonics habit. Okay, so if you have a habit of going for a pap smear, then it will really be helpful to you. Okay, so if you go for a pap smear, it will really be helpful to you. Okay, so what does the pap smear says? The pap smear says that habit. That habit is, H is for herpes. A is for actinomyces. Okay, B is for bacteriovaginosis. Okay, and I is for inflammation and IUCD. Okay, and T is for trichomonas. So pap smear is a good habit. Okay, remember pap smear is a good habit, and remember the mnemonics habit. Okay, additional information what she gives is, you have fever, you have mucopurulent discharge, vaginal discharge, VCS or CRP, and then laboratory evidence of chlamydia or gonorrhea by liquid based cytology. Okay, this is very important. Okay, PID asks in the exam. Now transmission. So how is the transmission of infection takes place? We already talked about that. It's a two entity component. One is a starting with the menses. Second one is at the time of menopause. In between, she's using contraception like IUCD, and she's having multiple sexual partners. Okay, so along with that, you can also add up on gynecological surgical procedures, childbirth in case of suspected chorioamnitis. For example, there's a prolonged rupture of membrane. Okay, there's a prolonged rupture of membrane. If there's a prolonged rupture of membrane more than 24 hours, more than 48 hours, what happens is there is high risk of two things. One is early onset neuronal sepsis, EONS, and other one is, of course, infection. Chorioamnitis may seed up and that leads to PID. Abortion, main important is the septic abortion. Septic abortion. So septic abortion cases always rule out PID. Okay, foreign body inside the uterus like IUCD, blood-borne infections, okay, and contamination from other inflamed structures like appendix. Okay, now there's one criteria where we admit the patient to the, so let's talk about the organisms first and then we'll come to, okay, so see, you need to remember that the anaerobic organisms plays a major role. Anaerobic organisms plays a major role like Bacterius vaginosis, Actinomyces, Mycoplasma hominis, Uroplasma urolyticum, TB, chlamydia, polymicrobial infection. Remember this polymicrobial infection, in which topic I talked about polymicrobial infection? I talked about polymicrobial infection in the case of garden. So this garden was associated with Gardnerella vaginalis. So bacterial vaginosis, all the causative agent for bacterial vaginosis can actually land up into PID. Why? Because it makes the vaginal pH alkaline, and we know that acidic pH is protective against the infection to go into the pelvic peritoneum, but alkaline pH can lead to the infection traveling upwards, and that leads to PID. Okay, now sexual transmitted disease. Okay, sexual transmitted disease like can be secondary to chlamydia or Neisseria. Okay, chlamydia, Neisseria, and aerobic like Haemophilus, E. coli. Basically, you should never forget bacteroids, E. coli, Haemophilus, Streptococcus, Mycoplasma, Bacterial vaginosis, Trichoplasma, Trichomonas vaginalis. Okay. Now, predisposing factors, same thing. It's written here again and again. Okay, it's vaginal douching, infection, poor health, immunocompromise, young age at first intercourse. Remember, if you have a traumatic component, like suppose early age at first intercourse, and there is two risk factors. One is cervical intraepithelial neoplasia, other one is, yes, PID. Okay, so what is important to treat in PID? So tubo-ovarian abscess, ectopic pregnancy, infertility. PID can lead to infertility, okay, and chronic pelvic pain recurrence. Now, how will the presentation be? So, how will the female present? So, of course, I already told you in these three criteria. Lower abdominal pain, discharge, fever. That's it. Major is that three, okay. Lower abdominal pain, discharge, and fever, okay. Irregular vaginal bleeding can be there, dyspareunia, dysmenorrhea, okay, and intermittent offensive vaginal discharge can be there, okay. Presentation: rise in temperature, abdominal tenderness, bilateral adnexal tenderness, tubo-ovarian mass, bulky tender uterus. All the things that I've already talked in three major criteria, okay, three important criteria. One is minor, additional, and major criteria. Manifestation of chronic PID. Now, what are the differential diagnoses? It can be an ectopic, torsion, appendicitis, endometriosis, ovarian tumor, cystitis. Okay. Now, the same thing when we talk about PID, there is minimum criteria, additional criteria, definitive criteria. Definitive criteria, we need three people: a radiologist, and histopathologist, and a surgeon, right? Additional criteria, she says that she has fever and abdominal tenderness and vaginal discharge, elevated ESS-CRP, I evaluated, and I looked into the lab documentation of cervical infection with gonorrhea and trichomonas, okay. And minimum criteria. So what is the minimum criteria? It's basically the Lower abdominal tenderness. Now I go for a vaginal examination. I look into the cervical motion tenderness. I look into the adnexal tenderness. Okay. Now lab studies. Okay. See, it can lead to hydrosalpinx also. Okay, hydrosalpinx. Now I want to actually I want you to understand this very important topic. Criteria for hospitalization. At what cases we'll go for hospitalization? Remember, it's very easy. First of all, let's understand in this way. Okay, so hospitalization, if you want to hospitalize the patient, so if you really want to hospitalize the patient, so what are you going to look for in the case of PID? So you're going to look for, number one, if you're not able to rule out any other surgical illness like appendicitis, number one. Number two is if PID is associated with fever ovarian abscess, if the patient is pregnant, if she's HIV positive and there's severe illness, nausea, vomiting is there. Okay. Surgical emergencies could not be ruled out. Severe illness, tuberous ovarian abscess, clinical failure of oral antibiotic, resistance. Now this is very important. Okay, so whenever we talk about PID, the most important becomes the treatment regimen. So I would like you to understand in this view. Okay, the treatment regimen, you have to mock up all the antibiotics over here. There is no hard and fast rule. Okay. So how do I remember it? I remember it in the fashion of mole, DCM, okay, DC and GC. Okay, mole means metronidazole, levofloxacin, ofloxacin. DC means ceftriaxone, cefoxitin and doxycycline. Doxycycline, ceftriaxone and metronidazole. And GC means gentamicin, clindamycin. You have to write this. Outpatient department, mole and DCM. OPD, it's a 3-letter word, MOL, DCM. Metronidazole, levofloxacin or ofloxacin. DCM, doxycycline, ceftriaxone, metronidazole. Okay. Inpatient, remember GC and above DC. Regimen A is DC, that is doxycycline and cefoxitin. And regimen B is clindamycin and gentamicin. Okay, you have to remember all this. Okay, this completes our PID.